HLH is a potentially life-threatening hyperinflammatory syndrome caused due to uncontrolled activation of T lymphocytes and macrophages that produce a cytokine storm. It is characterized by accumulation of activated lymphocytes and macrophages in various tissues and organs. There are two types of HLH, primary and secondary. Primary HLH has some underlying genetic disorder. It is autosomal recessive and it represents 25% of patients with HLH. Secondary HLH is acquired by some triggers such as severe infection or autoimmune disorder or malignancy. Pathophysiology of familial HLH. Gene mutation in these cases affect the ability of T lymphocytes and NK cells to synthesize and release perforin and granzymes. Perforins are needed to perforate the target cell, which helps in apoptotic cell death. So in absence of perforin, the apoptosis of this target cell doesn't occur, which causes cytotoxic T cells and NK cell signaling remain active, thereby resulting in continual production of inflammatory cytokines. These are the different phenotypes of primary HLH. The gene defect caused in these phenotypes affect specific step in the cytotoxic machinery. Like when the gene PRF1 is mutated, perforin protein is in defect, so no formation of fourth in antigen presenting cells. The disease caused then is known as FHLH2. Similarly, when the step of vesicle priming is affected, MUC13-4 protein is in defect. The gene responsible for this defect is UNC13D, causing the disease FHLH3. Vesicle fusion, when the vesicle fusion impairment occurs, the gene mutated is STX11 and STXBP2, causing the disease FHLH4 and FHLH5 respectively. In FHLH16 phenotype, there is no identifiable gene mutation has been found. Now the syndromes with partial oculocutaneous albinism, which is associated with HLH. In Griscelli syndrome, vesicle docking is impaired and the gene responsible is RAP27A. In Chediak-Higashi syndrome, the gene mutated is LIST gene. Similarly, there are Epstein-Barr virus driven and rare causes of primary HLH. They are XLP1, XLP2, ITK deficiency, CD27 deficiency, and X-Men syndrome. Now let's go to secondary HLH. Secondary HLH could be caused by both infectious and non-infectious processes. First, let's see the infections which can cause secondary HLH. It could be a viral infection like adenovirus, cytomegalovirus, dengue virus, Epstein-Barr virus, HSV1, HSV2, parvovirus B19, or bacterial infections like enteric gram-negative rods, Haemophilus, Staphylococcus, or Streptococcus. Fungus, Mycobacterium tuberculosis, rickettsial diseases, and parasites like Leishmania donovani or Plasmodium can also cause secondary HLH. In non-infectious causes, the first one is autoimmune disorders like systemic juvenile idiopathic arthritis, SLE, Kawasaki disease, and inflammatory bowel disease. We should note here the form of HLH caused due to autoimmune disorder is also known as macrophage activation syndrome, MAS. It is equally potential life-threatening condition caused by systemic inflammatory diseases. Non-infectious, the other causes of non-infectious cause of secondary HLH are immune dysregulation by drugs like methotrexate, sulfasalazine, malignancy like lymphoma, leukemia, immunodeficiency diseases like DiGeorge syndrome, chronic granulomatous disease, SCID, and inborn errors of metabolism. Now, when we see the pathophysiology of infectious HLH, following a viral infection, CD8 T lymphocytes undergo massive expansion and activation, secreting high levels of interferon gamma. This induces macrophage activation and pro-inflammatory cytokine production like TNF alpha and IL-6. Macrophages now spontaneously phagocytose blood elements and infiltrate various organs, resulting in massive tissue destruction and organ failure. This is the histopathology of a bone marrow aspirate in a case of HLH. We can see numerous hemophagocytic cells. This yellow arrow indicates one such cell. The phagocytic cells in these cases are CD163 positive. Clinical features. The initial signs and symptoms of HLH can vary, and it is often mistaken with some other disorders. So the signs and symptoms may be persistent high-grade fever, maculopapular or petechial rash, hepatosplenomegaly, jaundice, lymphadenopathy, respiratory distress, renal, if renal is involved, oliguria or AKI, CNS dysfunction may cause seizures, altered mental status, or encephalopathy. So the lab findings could be cytopenia, decreased ESR, abnormal liver function test, deranged coagulation profile, hypertriglyceridemia, low fibrinogen, hyperferritinemia, raised LDH, elevated soluble CD25. In bone marrow, as we saw that slide, we can find macrophage hemophagocytosis, USG to reveal any organomegaly. In cases of CNS involvement, MRI brain may show hyperintensities in gray and white matter. And for quantitative evaluation of intracellular perforin, SAP and XIP protein flow cytometry analysis could be done. And sepsis is an important differential of HLH. This is 2004 diagnostic criteria given by Histocyte Society. According to it, for the diagnosis of HLH, it must fulfill either one or two. One is a molecular diagnosis consistent with HLH. That means some mutation has to be present, or presence of 5 of the following 8 symptoms, signs, and lab abnormalities, like which are fever, splenomegaly, cytopenia, 2 or greater than 2 cell lineage should be affected, and hemoglobin should be less than 9 gram per dl, platelets less than 1 lakh per microliter, neutrophils less than 1000 per microliter. Hypertriglyceridemia and hypofibrinogenemia, hemophagocytosis in bone marrow, spleen, or lymph nodes without any evidence of malignancy. Low or absent natural killer cell cytotoxicity, hyperferritinemia, the serum ferritin should be greater than 500 nanogram per milliliter, and elevated soluble CD25, which should be greater than 2400 unit per ml. The treatment. The mainstay of HLH treatment consists of immunosuppressive, chemotherapeutic drugs, and biologics. The aim of the treatment is to dampen the cytokine storm which has been caused and eliminate macrophages and activated T lymphocytes. According to HLH 2004 protocols, the therapy consists of combination of dexamethasone, etoposide, cyclosporin A, and intrathecal methotrexate if any CNS involvement is present. Induction therapy consists of 8 weeks of chemotherapy, and the only known cure of primary HLH is stem cell transplantation. Continuation therapy should be done until the transplantation. Imapalumab has been recently approved by FDA for the treatment of refractory or recurrent or progressive or cases which are intolerant to conventional therapy. In secondary HLH, first of all, the underlying disease causing it should be identified and specific therapy should be targeted, coupled with supportive care. However, when treatable infection or other cause cannot be documented or clinical presentation is severe, the prognosis for secondary HLH is as poor as primary HLH. So these patients should also receive identical 8 weeks of chemotherapy. Prognosis. With no intervention in primary HLH, the median survival is 2 months from the time of diagnosis. Multi-organ failure and systemic infection are the most common causes of mortality. So the take-home message is HLH is a highly fatal disease and has poor prognosis, indicating to the importance of early recognition, diagnosis, and prompt initiation of treatment. Thank you.
First of all, very complicated. Slides are very good. Your